Um, Hello, everybody. Thank you for being here. Some of you already know me for many years, but I want to introduce myself for the others. I'm a clinician. I'm geneticist and pediatrician, and presently I'm working privately at the Morgagni Foundation in Catania, Italy. I used to be a professor of medical genetics at the University of Catania, but now I'm retired. I worked many years in Catania, first as medical student, as a postgraduate student specializing in pediatrician and as a pediatrician and medical geneticist. Then I had a job as a clinician and cytogeneticist. I became a university professor and director of the School of Specialization in Medical Genetics. I also founded and direct for many years the Hub Center for Rare Disorders in Sicily. This is a list of my postgraduate students that have come to some of the conferences and helped me with the work with the 11Q. These students have prepared theses on Jacobsen syndrome. My training in clinical genetics and cytogenetics was in Mount Sinai Hospital in New York first, at the University Hospital of Cardiff in Wales, and then at the East Birmingham Hospital in UK, where I met my Hulten. My personal experience with 11Q children started one day, I remember, because was born a girl with a very wide deletion, and I went to see her at birth, the 28th of December 1993. But very soon I started to meet other children. And so more than 200 I have seen up to date. And these that I mentioned, 200, are children that I personally visited. And also I have more than 200 questionnaires. The questionnaires have been printed, and you can have one, and you can fill in to give me information on clinical findings in your child. I also have 31 RMIs from children with Jacobsen. And more than 40 patients had a follow-up lasting from 2 to 30 years. The purpose of my work is to collect all information possible on 11Q patients, gain knowledge. Let's call them genomic disorders, because it's not only a chromosome problem, it's a genomic problem. It means that some of these children are not detected with chromosomes, but only with genomic tests, array, and be able to support family. How to do this? To collect all information regarding 11Q patients is necessary to get a complete clinical diagnosis. And this is through clinical evaluation and the questionnaire. And then a clinical follow-up. You must see what happens after. And then also get a complete genetic diagnosis. And because genetic tests become more and more advanced with times, update genetic testing. On the clinical ground, I created an updated clinical database. I put together and compare clinical information from patients with similar imbalance and try to understand what to expect during the patient's life, and identify if there are unusual findings. A patient has something unusual. Why? On genetic grounds, have the exact identification of the breakpoints and find, if possible, the factors predisposing to breaks. And this is my actual work. Is being done on this field. Try to understand why there is a break. Be able to support families is provide information on the natural history of the disorder. What are the problems that you will have to face with your child, how to cope with them, and provide information on recurrence risk in the family, in the same parents, and in siblings. First of all, what is Jacobsen syndrome? On genetic ground, is a partial chromosome deletion. On clinical ground, is a clinical syndrome involving all parts of the body from top to toe. To get a complete diagnosis, traditional karyotype would allow to identify only large breaks. When we had smaller ones, some were missed. And one help was given by FISH test, a stain of chromosomes. That in this picture you see one of the chromosome 11 is missing the red spot, which is the bottom of chromosome. Do you see the other one has yellow and red? The other one has only the yellow, the green, actually. So with FISH, you'd see more, but the breakpoints with traditional karyotype would be very rough. It would be impossible to see very small imbalances. The breakpoint may be even incorrect. And when I ask you where the breakpoint is, and you tell me it is at Q23.3, it is a 7 megabase bulk of DNA. It's very big. So one patient could have a break here, and one patient could have a break there, and there are a lot of genes of difference from one break to the other, all at Q23.3. So when you speak of deletion, the breakpoint should not be on chromosome, but on array test. To get a complete diagnosis, we need the array. This is what we see on the microscope, on the computer with the array. You see very neatly where the break is. And so you identify very precise breakpoint. You see if there is any additional loss or gain in another chromosome, in the same chromosome. Identify complex karyotypes. If you use a specific kind of array, which is SNP array, you would also be able to see whose parent is broken, is the broken chromosome. Even if parents are normal, one has given the chromosome that has is broken. If I'm not clear, please lift a hand and I will. So if you have arrays, you will get the breakpoint. If you have SNP array, you have more information. However, array is unable to detect balanced anomalies because it only detects gain or losses. And on the contrary, with array, we detect also VUS. VUS is variants of unknown significance. So when you make the test using array, you may detect unbalanced that mean nothing, that have no clinical effect. They are called VUS. Okay? When there is a VUS in a child, the doctor is not able to tell you what's going on. The VUS must be checked on parents, because if one also has that, it means it has no meaning. Okay? This is important in prenatal diagnosis, especially. Yes? You will know. I will tell you. Any test alone would provide incomplete or even incorrect results. Karyotype would have a gross definition of the breakpoint, maybe a misdiagnosis, and does not identify a complex karyotype. Array will miss all balanced anomalies and will detect also anomalies that mean nothing. To get a complete diagnosis on a child, you should have both chromosome analysis and possibly SNP array. What you see next is NGS, is next generation sequencing, is a sequencing of genes. And this should be done when there is something unusual, because you analyze also the sequence of genes on the other chromosome 11, on the normal chromosome 11, which is not balanced by the broken one. If you have a broken chromosome, the other compensate. But if you have something wrong in the other chromosome, you have no compensation. But I will go back to this, and I will try to be more clear. OGM is a new technique that puts together chromosome analysis as SNP array and helps identify more troubles in chromosomes that cannot be seen by one or the other, or even both, but not put together. OGM is a new technique that is only performed in research centers. If necessary, we can do it. Any results requires a clinical evaluation of the phenotype and technical update. One other thing is mosaic. What is mosaic? Mosaic is when a patient has a mixture of cells. Some have a deletion and some don't. But when we take a sample, a blood sample, we take a few cells from one tissue. We never know if a patient, or even us, we are mosaic, because we only analyze 2 cc of cells. We have millions of cells. The abnormal one could be out of the sample. And even if we detect mosaicism, the percentage that is found does not indicate exactly what is the percentage in the body of the child. This is important when prenatal diagnosis is performed. If they tell you that is mosaicism 80%, doesn't mean it's 80% in the baby. If they tell it's 1%, doesn't mean it's 1% in the baby. The percentage could be different. What happened? How we get mosaicism? Here we see an egg and a sperm. They join together, and there is a zygote, the first cell of the embryo. Then the cells start dividing. If very early a cell gets a deletion, all the cells that come from that single one will have the deletion, while all the normal cells will give birth to normal cells. So the baby would be mosaic. And if this happens very early in the embryo, the mosaicism will be very strong. If it happens later on during the development of the embryo, the child will have less abnormal cells. Mosaicism happens all the time, even in us. When a cancer starts, it's a mutated cells that starts a clone. So the phenotype in mosaicism could be straightforward Jacobsen, could be a mild Jacobsen, could look normal. And I repeat, since we analyze a sample, karyotype and array may turn normal. If mosaicism is detected, the percentage is not reliable. So we can have an adult that looks normal and in fact is a mosaic. Now I show you one lady. She's not Jacobsen. She has ISO chromosome 18p. And she had 2 children with non-mosaic ISO chromosome 18p. And she was a mosaic with a very low percentage in the blood. She was a normal woman with normal intelligence, with a little of resemblance to her children, with a closely located eyes. So let's go back. What is Jacobsen syndrome? It's a chromosome disorder, it's a genomic disorder, it's a multiple congenital abnormality, mental retardation, it's a contiguous gene syndrome, it's a syndrome due to chromosome imbalance involving a specific chromosome region. It's not a gene disorder. This should be, I strongly stress, it's not a gene disorder. A gene disorder is, remember that each parent gives one of the couple of any chromosome. Any chromosome, you have one from the father, one from the mother. So if you have a recessive disorder, it's because you inherited 2 copies of the gene are both abnormal, either both abnormal or one abnormal one missing, or both missing. So both must be not working. A dominant disorder, one affected copy is enough, but the gene must be abnormal in some cases. In other cases, the gene must be additional. There must be more of that gene. In some cases, the gene must be missing. So A dominant disorder is not present if just the gene has something wrong, but must be wrong in the right way for that disorder. Okay? The second two, additional or missing dominant disorder, only if there is a precise dosage for the gene. When I explain this to my students, I say that if you make pasta, you can add tomato sauce as much as you want. There is no dosage problem. But if you add too much salt, you cannot eat pasta. So there are genes that behave like salt in pasta, and genes that behave like tomato sauce in pasta. Okay? Jacobsen is not a single gene disorder, but is not a collection of single gene disorders. Is not a collection of single gene disorders. So when you say that there is a missing copy of chromosome 11q, and you ask me how many genes are missing, you'd be frightened. I cannot read how many genes. In the whole portion, there are 346 genes. But if you see, these are some, and the only one that we see always, almost always in Jacobsen is a bleeding disorder. If you see here, arthrogryposis, I have not met any child with arthrogryposis. It's a joints that cannot be bent. They are fixed in a position. It's very severe because they have one copy missing, but the other is working. If by chance a carrier of arthrogryposis as a child with Jacobsen and loses the normal allele, one is lost, the other is wrong. And we would get a single boy with a girl, with Jacobsen and arthrogryposis. But these are not diseases that we see in Jacobsen syndrome. The only thing we see is bleeding disorder. There is missing one copy of this region. So it is very important to know how are the genes on the non-deleted chromosome 11, at least in those patients that show something unusual, a phenotype that has something in addition. Okay? Jacobsen syndrome is a contiguous gene syndrome, missing a fragment of a chromosome containing a number of genes that are contiguous. It's not the genes individually that give the phenotype. It is the piece of genome missing that give the phenotype. Clinical picture of any contiguous gene syndrome is dysmorphic feature, intellectual disability, physical developmental abnormality, organ malformation. Any, even if it's not a deletion, but it's a duplication, you'd get this. Not the effect of single genes. But the picture is consistent, but is variable. The bigger deletions have the worse phenotype. But always these four clinical findings will be there. When we studied the breakpoints, we thought there were few patients. Each column is one patient. And those are with the wide deletion. This is the smallest deletion. So when we saw with the first arrays we performed in the olden days, we thought that some had the same breakpoint. But when we refined the breakpoints, we see that virtually each patient has a breakpoint, different from the other. We also had this patient that has a wide deletion and whose mother was carrier of a fragile site. I also had the second family. The first one is from Australia, but the second family is mine, where a mother with carrier with a fragile site had 3 children with a fragile site, more evident, and mosaicism with loss of chromosome 11q. When there is a fragile site, the chromosome breaks and loses bits. Before it can divide again, it must heal the break. So the healing could be early or late, and the breakpoint could be in different places, even in the same family. Okay? Predisposing factors may be fragile sites, variants that save mosaicisms. We now know that some variants give advantage to the cell and then save cases of mosaicism in parents. Now let's analyze breakpoints. There are wide and small deletion. I want you to look at the blue ones. They are the first one, the large one, is an interstitial deletion. You see the red spot, that bit is not missing. It's interstitial deletion, but the patient has Jacobsen. So according to this patient, that region, very terminal, is not important for Jacobsen. Then we have this second one. It's a patient with a very small deletion, but with full Jacobsen syndrome. She also has duplicated kidneys, everything. And she has much smaller deletion, including terminal. But then you see the last one, which is very terminal deletion. And this patient does not have Jacobsen syndrome. So that part is not important for Jacobsen, but only this region is important for Jacobsen syndrome. And if the lesion is wider, if the lesion is outside, the phenotype will be different. But if it's wider and the Jacobsen syndrome is included, there will be more symptoms. If it's smaller, there will be less. Okay? So the deletion could be interstitial or terminal. But there is a wide clinical variability. You see here samples of patients with the deletion from the widest to the smallest. And you can see this patient, that is the daughter of the mother carrier of a fragile site I showed before. has just the same face as this patient that is much smaller deletion. Okay? And this patient has a similar deletion as the previous one, but looks normal on the face. Nothing. And you can see this is the patient that is the smallest deletion. The face shows fully asymmetrical, ptosis, and so on and so forth, the syndrome. You also see below 2 patients with the same breakpoint with different shape of the head. So the phenotype is more severe in wide deletion and less severe in small deletions. But there is a wide clinical variability. So you may find that some symptoms are less even in a wide deletion, and some symptoms show in a small deletion. Why? Expression depends, of course, on the region. If we go outside, the phenotype changes. Size of the deletion. Genes involved. Mosaic or non-mosaic condition. If we see a wide deletion in a patient that shows normal or almost normal, even if the karyotype is full or the array shows the full deletion, may be a mosaic. It's variable if there is an additional imbalance. And then there are positional effects. What is positional effect? If you put a gene that should be influenced positively, work more for the position he has, and you put it in a position where it is turned off, you'd have a change in the phenotype. Even if nothing is missing, nothing is in addition. So if you move pieces of chromosome, a balanced translocation, a balanced inversion, without any loss, there may not be an effect. And then there is the genetic compound. We are talking of chromosome 11 with deletion, but there is the normal chromosome 11 that has got its own genes, not helped by the deleted one, and other chromosomes. And then there is the environment, epigenetics. And this is where you work when you do physiotherapy, logotherapy, and you act on epigenetics. Is how to modify the effect of genetics using the environment. Contiguous gene syndrome, the picture is consistent but variable. Depends on what's on the non-deleted chromosome 11, could be checked with NGS. What is on the other chromosomes, again, can be checked with a wide NGS. But NGS, next generation sequencing, would detect a huge number of variants. So we cannot do it blind. We must do it in view of a specific finding, clinical finding. You cannot do, well, I have this, I do NGS and I find what's wrong. No, because each of us has 20,000 variants. So if we want to check if there is a variant that is responsible of a disorder, we must look into that disorder and see if there is something wrong. Is a contiguous genes disorder, is not a collection of single genes disorder. And both parents contribute to the phenotype. So if you are the one that has given the wrong chromosome, your husband or your wife has done is part of the job. Family history. Jacobsen is usually sporadic. Recurrence is very rare, in any case. But in a family where a case has been, I would suggest to offer the possibility to have prenatal diagnosis. Possibility to have prenatal diagnosis, that does not mean that the family must have prenatal diagnosis or the family must have interruption if the child has something wrong. This is a personal choice of the family. Let's see, low risk if both parents have normal karyotypes. High risk if one parent has Jacobsen, is mosaic, or is carrier of a balanced translocation. But high risk is also if both parents have normal karyotypes, but one is mosaic and doesn't know, has a fragile site and doesn't know, has a monosomy rescue and doesn't know. So even if you can be almost safe if both parents have normal karyotypes, I would also offer prenatal diagnosis. Recurrence risk. We calculate also on family history. So we have this family, we know both parents are normal and the child is affected. We must say the risk is low, stop. If we see this family, they are normal parents with an affected child, but these parents have normal siblings, and the affected child has normal siblings. This is a reassurance that the family doesn't have a risk factor. But if the same family, there are miscarriages, those two spots are miscarriages, or neonatal death with malformation, you must think that there may be a risk. And if you have this family, two affected members, one is the son and the other is the sister of the mother, you know that the mother has something. Either it's mosaic, or is translocated, or is a carrier of a fragile site. And the same if it's on the paternal side, the father must have something. And if two parents with normal karyotype have two children affected, one of the two must have something. Either as a balanced translocation, this is the most common finding, or one parent is mosaic, or as a fragile site. And it is important to know, but because you may inform other members of the family that there is such risk. Siblings of the patient, siblings of the parents. If the father is carrier of a balanced translocation, the risk of recurrence is lower because the father has millions of sperms. Some are affected with the abnormal chromosome. And those usually are slower, have double head, double tail, break. So in case of a paternal carrier, if the father is carrier, there may be reduced fertility, but there is less chance of having a recurrence. If the mother is carrier, she only has one egg each month. It could be normal or abnormal. And the pregnancy would start, maybe it would miscarriage. So if the mother is carrier, you would get more easily miscarriages. Prenatal diagnosis, I think, should be offered if there is one case. Chromosome analysis with FISH is able to detect parental analysis. Chromosome FISH was, what was, parental analysis. We must do chromosome analysis with FISH, would detect balanced translocation. No point doing array, because array will be normal in any balanced karyotype. Chromosome array is normal. But if the child has a VUS, something is not easy to interpret, to understand what's wrong, it should be done. Because if one parent has the same VUS, it means the VUS is not responsible. Ideally, if parents have normal karyotypes, we should test to identify mosaicism and molecular test for fragile sites. In this case, if we know the parental origin of the deleted chromosome, we know it's paternal or maternal, we do this work that is very, very important, very strong, very tedious. We would do in one parent, the one that we know has transmitted the wrong chromosome. Any results require a clinical evaluation, a technical update again. Why is that? The precise diagnosis allows us to take care of the patient in the most appropriate way. Update the diagnosis would give more details on the reasons, recurrence risk, many information. Analysis in the parents allow to identify factors that predispose to recurrence and helps decision making. Makes it possible to identify other members in the family. What happens during the Jacobsen syndrome life? Pregnancy is normal in 2/3 of cases. In 1/3, there are problems. The growth is retarded in 1/2 of the cases. There are miscarriage, threatened miscarriage, preterm labor, abnormality of the placenta, polyamnios, maternal high pressure. And if we do scan is normal in 61% of the cases. When it's abnormal, there is a reduced growth, heart malformation, kidney malformation, prenatal edema. Screening by 3 tests is normal in the majority of cases. If we want to do prenatal diagnosis, we don't use NIPT, non-invasive prenatal diagnosis, which is not a diagnostic test, but is a screening test. We should go to amniocentesis, CVS, with chromosome analysis and array, or array even without chromosome analysis. Array would detect imbalance. At birth, we have a small baby with dysmorphic face, heart malformation, bleeding disorder, may have pyloric stenosis, may have feeding problems, may have pulmonary problems. At the diagnosis, any age, the checkup should be complete, from top to toe, by clinical geneticist, clinical pediatrician, neurologist, cardiologist, all specialists. The child should be checked because all these area of the body can be affected What does the pediatrician find? Reduced physical development, malformation, kidney, heart, gut, genitalia, problems with swallowing, vomiting, constipation. The hematologist, immunologist would find low platelets. Remember that platelets, when the child grows, reach almost normal values, but they are still abnormal in function. And there may be low white blood cells, anemia, low B cells, low T cells, low immunoglobulin. The cardiologist would find cardiac malformation, but heart must be checked along the whole life of the child because there are some acquired problems. Like aortic coarctation may happen afterwards, or other large vessel coarctation may happen afterwards. The neurologist would check for developmental delay, mental disability, autism, brain malformation, seizures. One aspect I have not treated is psychosis, but I would like to see in a more grown-up if there are problems with psychosis. Clinical findings, again, endocrinologist, ophthalmologist, all the specialists must check, may find or not find these abnormalities, but they must be checked. And then heart scan, ECG, basic MRI of the brain, EEG, abdomen scan, double kidneys you'd never seen. There is no way to see duplication of kidney, which is seen in these children, only if you do the scan. What happens is if there may be infections that you don't see until the kidney is destroyed. So a scan of the abdomen once in life must be done. And then you decide if you want to do more. Complete blood assessment, complete genetical assessment, blood count, immunity, endocrinological, routine urine. And after the first checkup, you can tailor an evaluation from time to time according to what the boy or the girl has. What's wrong? Instrumental test, MRI when required, heart scan every year, abdomen scan, X-ray if required, when required, blood test every year, at least every year, routine test or when required. And then let's see how the patient grows. In this scheme I put here, I will show the number of children with short stature on that age, on tall stature on this. Most children with Jacobsen syndrome are short. The first column is the column of the how many children with Jacobsen are short. There are a few that are almost normal, a few that are tall. If the stature is very short, check growth hormone. But I would check growth hormone in any child with Jacobsen. Okay? If you deal with numbers, you know that you analyze a number of data, any data. We take the weight of everybody in this room. If the number is enough high and the group is homogeneous, you'd get this curve. You'd get a mean value, most people would be around the mean value, and there will be a few short and a few too big and few too small. But if you get this kind of curve, it means that there are two groups. If we are saying weight or height, if you put children and adults together, you would have two peaks. The children would have a mean stature, a mean weight lower than the adult. Okay, if you get two peaks on the Gauss curve, it means that there are two populations. This is the head circumference in Jacobsen. The majority of children have normal head size, but too large for the height. So they look with a large head. The head is large for the height. There are few, but there is a peak of very small head. And there is a peak of very large head. Definitely, we have three peaks. So we have three populations. The group of Jacobsen is made of three kinds of Jacobsen. And we need to perform MRI in the ones that have very large head and very small head, but I would do to all. Okay? Clinical findings suggest something to do. I found that the seizures and iris coloboma are very, very rare in pure Jacobsen syndrome. If we have seizures or iris coloboma, I would suggest to check karyotype again because there may be an additional abnormality. If there are pulmonary infection, warts, a serious immune disorder could be suspected. If the head is too small or too large, there may be a brain malformation. If the stature is very short, maybe low growth hormone, low thyroid hormone. I'm going to finish. Now, craniosynostosis or any kind of trigonocephaly once was thought to be the most common finding in Jacobsen. Is not. But when the head is closed, because the head should be large, it is wise to operate to allow the growth of brain appropriately. Some children with chromosome disorder have small head, craniosynostosis, but the brain would not grow. They wouldn't need to have an operation. Jacobsen syndrome may be wise. The neurologist would check the growth of brain if the craniosynostosis does not allow the brain to grow, it must be operated early. Severe ptosis must be operated early as well. If they have one eye, they would lose that eye. That eye would not see anymore if you let it covered for a long time. If you have both eyes, the child will have difficulty walking. So it's not such a terrible operation, but it's very helpful for children. Anyway, 90% of children have surgeries. Heart, skull, pyloric stenosis, eyes, ear tube, important, less important. Complications, there are in a quarter of cases. There may be bleeding, but as we know that, we can afford because we can prepare blood, we can give blood before operation, we can be prepared to bleeding. Anesthesia is because the throat is narrow, so you must know that if there is an operation with the Jacobsen, the tube should be very small. There are risks of cardiac arrest, respiratory arrest, pneumonia, infections, and the outcome could be a good result. There may be relapse. I have seen many relapses in ptosis and what I collected. And abnormal scars that grow keloid, thick and colored. This is not terrible. And then to finish, what are the life-threatening pathologies? Congenital heart malformation or acquired heart malformation, heart failure, low blood level, sudden bleeding, immunodefect, infection. There is no clear evidence of risk of cancer. And now I have finished. I want to show what I see from the window of my house. This is Acitrezza in Sicily. Okay, I'm finished. Are there any questions? Nigel.
Right at the start, you mentioned RMI.
Sorry, I
What's
might
that?
use the Italian. Is magnetic resonance of brain. I use the Italian. Sorry. No, so I got everybody confused.
Die mozaïektechniek, of om dat te ontdekken, dat is iets
somebody
nieuws.
Must translate.
Die mozaïektechniek, dat is iets nieuws. En wij zijn
no,
natuurlijk
it's not new. It's not new. The thing is that you have to count, if you analyze chromosome, you must count many. I found the lady with the mosaicism that had been missed. I found counting 300 cells. And in 3 children with the mother having the fragile site, they were mosaic. I counted more than 500 cells. That you must be there. Sometimes it's easy. If you go to a lab and ask for a search mosaicism, they would count 100 cells in good laboratories. But there are ways to understand that it was a mosaicism indirectly. There are cases when one parent, the mother usually, instead of having 2 chromosomes 11, has 1 chromosome 11, and the other one is a copy of the same that chromosome. We can see that with the SNP array only. If this is the case, she had a breakage, lost a piece, and the piece was renewed by a new piece, copying the leftover chromosome 11. This has been shown.
Nou, dit begrijp ik wel, maar ik vraag het eigenlijk omdat in de tijd dat SME is gediagnosticeerd...
No, non sento niente. I only...
hebben wij eigenlijk ons bloed natuurlijk ook laten testen. En bij ons was het allemaal normaal. En nu vraag ik me eigenlijk af, misschien is er door deze techniek toe te passen, is er misschien bij ons ook iets te vinden. Is het dan dus nuttig om alsnog zo'n test te doen?
Not a single word.
Nee, ik wil niet nog meer kinderen.
I understood everything you said before, but at the time when Esme was diagnosed, they tested normal. And they were wondering, is it useful for them to be retested?
You are not going to have children now. It might be interesting, but I would like to go through your files first to see if there is any indication. Okay, unless you have some symptoms. No. No.
They also have a son, and it might be interesting for him to know the situation of his parents, just in case he wants to have children at a later date.
If you have a mosaic, either your child is affected or is not. You cannot give both cells. When you make a child, you only give one cell. Okay? So there should be no... we don't know everything, but I think there is no risk.
And I have a question about about the heart. You told that even though the heart is checked and found okay, regular testing thereafter is necessary? Because
I would suggest so, because I have seen a few times coarctation. It means that shrinks a vessel, so it's not just heart, but also big vessels. Renal vessel, vessels to the brain, aorta.
Okay, and at what interval do you suggest? Every year, every 2 years, or even?
You check once. If there is indication to do it, you do more frequently. If not, once a year.
Okay, thanks.
Hallo, ich wollte auch fragen, ich habe 3 Kinder, 2 bei mir Kinder mit Jacobsen-Syndrom, ja?
Sorry, I didn't understand.
Ich habe 3 Kinder, 2... ja? Ah, okay. 2 Kinder bei mir mit Jacobsen-Syndrom und also bei meinen Kindern in der Mitte ein Stück fehlt. 86 Genen. Und ich wollte fragen, wie hoch, ich weiß nicht, kann man das feststellen, wie hoch ist das Risiko für meinen Sohn? Ob er auch betroffen oder ob wird er gesunde Kinder haben oder mit Jacobsen auch Risiko?
Is it on? Yeah, it is on. She has 3 kids. 2 of them have Jacobsen with a middle deletion.
With?
Middle, yep. Interstitial deletion. How high is the risk for her 3rd child, her son, to have children with Jacobsen or will those children be healthy?
I would like to see your files. Did you bring them? You can send. Because...
She has already sent them.
Ah, you did.
For 10 years.
10 years ago.
I must go through then. You know, interstitial deletion is more rare. I think it's outside the Jacobsen region. Is it? It should be outside the region. I must go and look into those files. I have been dealing with the terminal deletion, but if it could be very interesting to check if there is something, because one of you must have, did you find out if one of you has something on chromosome 11? What's wrong with you?
Bei mir die Genen umgedreht in der Mitte.
With her, the genes in the middle, the interstitial genes have been reversed.
So she has an inversion.
Inversed.
I would like to see the files again. If you contact me afterwards, I don't have anything here, but I have everything saved. Okay? I will go through.
Danke.
Thank you.
Okay.
Finished?
I think
Thank you, everybody.
Thank you very much.